Clinic.
Thank you. I'd like to thank the organizers for the opportunity to present. Pat, actually, you haven't said anything halfway between us. You're spot on, and I agree with what you said. 50%, there's real equipoise there. An important topic: functional tricuspid valve regurgitation associated with mitral valve prolapse. What do we really know? So, this morning I gave a disclosure that it was snowing in Minneapolis, and as an update, it's still snowing. And in fact, the snow plows are all in their garages for the summer, and many snow plows are unable to be extricated from the piles of snow. So it's the largest snow in the history of Minnesota. So welcome to Minneapolis and Minnesota. So let's talk about, on that note, let's talk about something sexier than snow. Mitral valve disease, mitral valve prolapse, i.e. on the left. The patient I repaired with cords and a resection. But alas, the preoperative TT shows this degree of tricuspid regurgitation. This is what we're speaking about today. This is an asymptomatic female with a normal RV, a normal LV dilated, but normal, asymptomatic, no pulmonary hypertension, no other comorbidities, no radiation, ischemic disease, rheumatic disease, etc. So really, let's frame the argument here. We're speaking about degenerative valve disease, mitral valve disease with prolapse. No tethering, no ischemia, no radiation, no congenital disease. So 4 questions, or 5. Why worry? Number 2, what is the fate of uncorrected TR in this situation? Let's not cite rheumatic disease or the others. Number 3, what's the consequence of delayed left-sided reoperation? Number 4, is there a survival penalty? And number 5, is there a difference between repair and replacement? So what is functional TR and why worry? So as Pat alluded to, functional TR is TR without pathologic condition or anatomic abnormality of the tricuspid valve, leaflets or chordae. So I'll give this talk and someone will come up to me and they'll say, well, what if there's a pacemaker lead induced TR? Well, that's not the same situation. That's not functional TR. Functional TR is caused by a functional consequence not related to the valve or subvalve or apparatus. Now, the argument that people give when entering into this so-called debate, I really don't think it's a debate. I think we're all on the same page, but let me clarify. People get a little sensitive, a little fussed about the fact that everybody must follow this paradigm. So in other words, a volume overload imposed by mild to moderate TR leads to increase in radiation, increased wall stress, increased annular dilatation, and begets more TR. In all situations, no negotiation. Well, let's look at what Duran says. TR's closing ability is strongly related to RV contractility and geometry. Regurgitation in the presence of an anatomically normal tricuspid valve, i.e. functional insufficiency, is a sign of poor patient prognosis. It reflects a more advanced myocardial involvement. Again, that was largely from rheumatic data, rheumatic patients. The TR dilemma is as follows, however. Reoperative TV surgery is high risk in some, granted. The perceived cost of concomitant intervention at primary operation is low, and I presume, in fact I know that's what Dr. Bowling will say, and I do say that in my own practice when I'm speaking about other diseases. However, there are contradicting reports ranging from non-significant impact to severe morbidity and mortality. There's more of their confounding etiologies of primary and secondary TR in the studies to date. So the pitfall of looking at all the survival data in the published series are as follows. TR has always been associated with other significant diseases beyond degenerative mitral valve prolapse, which we know is a low-risk disease that mitral valve repair is capable of restoring survival to normal. Studies have examined the underlying disorder rather than the valve lesion, and that dominates the clinical picture. The independent impact of TR, thus, on morbidity and mortality remains unclear. Second question then, does functional TR require correction at the time of degenerative mitral valve repair? So we looked at this. We included patients undergoing degenerative mitral valve repair for leaflet prolapse with or without ASD or PFO closure, nothing else. They all had some degree of coexistent TR. Now, I agree with Pat. There are surgeons at our institution that will repair moderate TR. There are surgeons who won't, based on several a priori qualifications that I'll list in the next slide, and all would repair moderate to severe, or severe TR. So let's just get that off the docket right away. All patients in this series had freedom from right heart failure. We excluded, and this is very important, concomitant CABG, secondary major procedures other than closure of a PFO or a small ASD, congenital rheumatic or ischemic MR, cardiomyopathy, endocarditis, or primary pulmonary disease, or those who had tricuspid valve anatomic features that required correction, so stenosis or other abnormalities. So what are you left with? You're really left with pure functional TR that's a bystander. So what happened to TR with time? We followed this specific group of patients. Now, some may at this point go, well, you're really selecting down a group of patients that's not looking at all TR, and that's precisely the point. You have to qualify which population you're speaking about, because the people up here, we all have mixed practices of mitral valve disease, but a large proportion of our practices involve only those with degenerative leaflet prolapse. And once again, they're asymptomatic, they're young, they're functional, and they're healthy people without RV dysfunction. So let's look at what happened. If a patient had grade 3 TR, which in this series quantified as moderate, then that stayed pretty constant with time. Grade 1 to 2 TR stayed about constant, maybe a slight increase, but not statistically different. So the bottom line is during long-term follow-up, there's no significant change in TR with time. What about reoperation? Did this drive reoperation? Well, the answer is no. Only one patient 5 years later following mitral valve repair who had severe RV dysfunction following their mitral valve operation underwent re-repair and concomitant tricuspid valve reoperation. So what were the independent predictors in multivariable analysis of progression of TR from pre-op to follow-up greater than 5 years? This is substantial midterm / beginning long-term follow-up. Prior atrial fibrillation. Lower grades of TR progressed slightly, but not significant. Slightly, but not clinically significantly. In other words, it was not associated with an inordinate increase in New York Heart Association class or right heart failure. Female patients and diabetics. Third question, is functional TR a consequence of delayed left-sided operation? So let's just change tacks for a second and think about this another way. We looked at LV mass regression following mitral valve repair, again, in the same population of degenerative mitral valve patients. This is what we found. Those with the lowest degrees of LV mass had nice regression over time and it stayed constant. Those with the intermediate group of preoperative LV hypertrophy decreased with time and stayed constant. However, those who underwent delayed mitral valve repair, i.e. with the highest degree of left ventricular hypertrophy preoperatively, were limited in their ability to regress to normal LV mass with time. Now, what we found in that group was interesting. It was those who had the highest degrees of initial and maintained LV mass that correlated with those with moderate TR. So then the logical question is this. So they had LV mass. Those are also the patients with the higher degrees of TR. Why not repair it and ameliorate it at the same time? So we did a further subgroup analysis. We found, regardless, matched patients, of course, regardless of whether TR was addressed or not, this did not augment the patient's ability to regress LV mass with time. Next point, does right ventricular dysfunction precede TR development? So in other words, is TR development a consequence of delayed left-sided operation? And as opposed to waiting for patients to come to us so we can repair two of their valves, why not allow them to come to us so we can repair the mitral valve, preserve the LV, preserve the RV, and obviate the need for tricuspid valve operation? So to answer this question, we looked at a newer modality of LV function and RV function called speckle tracking. What we found is that strain was preserved in the control group without MR TR, as well as those with degenerative MR minus TR, so no functional TR, but was abnormal in those with functional TR. So in other words, global strain, by the time global strain became abnormal, TR also arose. So they're simultaneous events. And the question is, what comes first, RV dysfunction or functional TR? All of us who deal with mitral valve disease would conclude that it's a delayed left-sided operation that leads to this condition. Next question, does moderate functional TR impair survival? So we don't have good data in the literature, and certainly in our series that hasn't shown that to be true, but we did look at a population of patients with idiopathic TR. So what does this population entail? So these are patients with TR that's functional, i.e. there's no organic disease of the tricuspid valve, but it's isolated functional TR. Moreover, it's in the absence of other confounders such as radiation, pulmonary hypertension, et cetera. What did we find? So trivial TR are all all of those with an ERO of less than 0.4, i.e. sub-severe TR, were equal in their long-term survival ability. However, once patients developed severe functional TR, their survival with time was diminished. In other words, severe functional TR is a bad thing, and we all agree with that. What about heart failure and death? We'd all, as we expect, see the following trend in our own practices, and indeed we did in the study as well. Once patients develop severe functional TR, their incidence of heart failure or death increases with time. Does replacement matter? A lot of studies allude to this, i.e., well, those patients underwent mitral replacement, therefore the results may be different. Well, apparently not so. We looked back over 20 years of patients who underwent mitral valve replacement for degenerative mitral regurgitation, albeit a smaller subgroup with slightly different conditions, but we propensity matched. And what we found is the following. Females, AF became borderline significance, but over 5 years it was did not reach P of 0.05, and lower preoperative ejection fraction, as well as higher right ventricular systolic pressure, i.e. pulmonary hypertension, all predicted progression of TR with time. However, replacement did not. Now, Dr. McCarthy alluded to this paper, 1,000 patients who underwent mitral and with or without tricuspid valve repair, and actually the data is interesting. It shows some trends, but when it comes to the conclusion of statistical analysis, the following was concluded at the end of their paper. Early or late clinical benefits of concomitant TR, or tricuspid valve repair for mild to moderate TR, i.e. a group we could probably all agree with, during mitral valve surgery were uncertain, though in long-term follow-up in 959 patients. Several preoperative factors in the performance of a Mayo procedure for AF seem to be more important than tricuspid valve repair and overall clinical outcomes. So that's interesting data. So in conclusion, we look at this patient's TR after surgery on the table, and it decreased with time during follow-up transthoracic echocardiogram. This is the patient I repaired earlier. Mitral valve repair for prolapse with moderate TR. TR is a marker, not necessarily the problem in this patient population with sub-moderate tricuspid regurgitation at the time of degenerative mitral valve repair. Moderate TR, a sub-moderate TR rather, rarely progresses, and that's been shown in our numbers to date, and people debate that, but we have to look at the numbers of what we have. There's no excess risk in this population, therefore. The reproducible predictors of TR progression in our series seem to be older patients, poor ventricles, and those with atrial fibrillation, and therefore this may be a target for concomitant operation. Further analysis of the predictors of TR progression in equivalent populations is required. When do we intervene? Again, mitral valve disease with severe TR or moderate to severe TR and right heart failure symptoms, atrial fibrillation, pulmonary hypertension, structural tricuspid valve abnormality, progressive valvopathy situations such as radiation, drugs, drug-induced disease, rheumatic, carcinoid, and congenital. Thank you very much for the opportunity to present our data today.